My name is Dr. Randy Wax. I'm an associate professor of critical care medicine at Queen's University in Canada. I'm very excited to be the moderator for tonight's webinar entitled Recognizing Deteriorating Patient Conditions, Safety 3.0, What Social Media Taught Us About Safety in Hospitals. I'm very excited to introduce our speaker, Dr. Chris Suby. He's a consultant physician in acute medicine, respiratory and critical care medicine, and a lecturer at Bangor University. He's trained in multiple countries in the United Kingdom, Germany, France, and the United States. And he's also worked for Médecins Sans Frontières in Angola. He was part of the Quality Improvement Faculty of the Royal College of Physicians, and he's also completed an Improvement Science Fellowship for the Health Foundation. Very excited to have Dr. Suby take over and start the talk. Thanks so much for joining us tonight.
Hi, and it's a great honor to be invited, and we got a slight drift in the time here. Not only am I in a different time zone, it's also significantly later here, but I hope that not everybody will have to reach for their coffee. So we're going to try to do this a tiny bit with interaction. And so I was wondering whether you could get your mobile phones out and dial into www.menti.com. And once you're done that, it will ask you for a code, and the code is 236701. And you can see that hopefully on the top of the screen there. And then what I wanted to ask you first is whether you could just type out, your biggest challenge in the care of deteriorating patients, while we're hoping that there's still a few people coming in and giving people time to just settle in and get comfortable, if that's okay. Just while we're doing this, a couple of words to myself. So as Randy said, I'm a practicing physician, and I've been fortunate to have opportunity to work on a number of research projects in relation to deteriorating patients, some of which I'll present to you. I guess the thing that I'm most known for is our paper on early warning scores. We were the first group ever to examine those type of tools. And so we'll talk a bit about that later. I apologize for the long title. It sounded a good idea at the time, and maybe it wasn't such a good idea. I hope that you'll be able to use this. There's people starting to type things in now. That's really good. Recognizing who is sick and who isn't, that's definitely something we're going to cover. Early symptoms, we're going to talk about early symptoms. That's really good. Yeah, so if who should go to ITU and who shouldn't? Now that's a really complicated question, and that might be different in different healthcare systems. We've got some guidance when patients should go to intensive care as part of the International Consensus Conference from 2018, and they're going to cover that. So I'll just give you another minute to gather some more thoughts of what people are hoping to get from today's session, and then I'm going to start with the official slides. Good. Now, I can't see how many people are in the session, but I hope that you can all see the slides. And then if you're dialing in, if you haven't had the time yet, that you dial into this website at menti.com. And we're going to use this website throughout the presentation so that I can get your views on specific problems and we can measure those. Getting physicians to listen to nurses when they are worried, that's a really, really good challenge. And I think this is one of the areas where I think standardization might help. Definitely something we're going to talk about. Looking after lots of patients, having lots of data, organizing it to see what is deteriorating. Brilliant. I've got a slide on that. Remembering to think about differential diagnosis when showing. Good. So I think you're in the system now, and I can gently start off just as a precursor. Can you tell me briefly what your working role is? Are you working as a nurse or a doctor in intensive care? Are you working outside of intensive care? Are you a specialist in tech? or are you a manager or a managerial colleague? Website is still on the top, menti.com, and the code is 236701. Just going to give people a minute to do that. Good. So there's at least one clinician who works out of intensive care. And this is one of the challenges of rapid response systems, who is actually looking after critically ill patients. Now, I'm trained as a physician and as a critical care physician. As a critical care physician, I definitely feel responsible for patients who develop critical illness. But I know that many of those patients will not be under my care, working in intensive care. And that a lot of the skills that are required are actually also on general floors. It's important to have this conversation between all involved parties. And I'm pleased to see that there's colleagues with a managerial brief. And I hope that I'll be able to have some content that's relevant for your working practice. Good. Okay. So what we're going to cover today is we're going to provide some evidence on failure to rescue from hospital, from studies around the world, describe elements of successful rapid response systems, discuss advantages of custom-built versus uniform rapid response triggers, and I'm going to share some of the experience of our work with electronic notifications as part of the VITAL-2 study, and highlight some of the challenges if you transition from a traditional paper system to an electronic system. These are some of the groups that I worked with over the last few years to develop some of this research as a note of thank you. And these are my conflicts of interest. I've worked on contracted research for Philips Healthcare and received speaker fees. Now, where do I come from? I'm obviously from the United Kingdom, though I'm born in Germany, and there's two interesting facts about the area where I come from. The first one is this. This is the village with the longest name of any village ever. It's Schlanfe-Puchgwen, Gichgogerch-Windrobuch, Chlantesilje-Gogogoch. And this is literally 2 miles from where I'm living. This was a Victorian stunt to get visitors to the Isle of Anglesey, where we live, and that seems to be still working today. Now, the other factoid is this place is Pennygoret Hotel in Snowdonia, at the foot of Wales's highest mountains. This is where Sir Edmund Hillary practiced for the ascent on Everest. And in a sense, we have locally championed innovative solutions that have traveled to other bigger places and continue to do that. I want to first think a bit about what failure to rescue is and how it presents in different hospitals around the world. And after discussions with Randy in preparing this session, we thought that we start with a patient story. And I want to start with Helen Huskell's story. Helen Huskell is a collaborator and a real inspiration, and she's the mum of Lewis Blackman. Lewis Blackman is a 16-year-old boy who a few years ago is admitted to hospital to have some thoracic surgery, to have some rib deformities corrected. And I want you to interact a bit with me as we're going through this patient story. So he comes into hospital on a Thursday morning, and he's meant to go to the children's wards, but there's no bed on the children's ward. So he's admitted to the adult ward. And you can tell me a bit, whether that's something that worries you, whether it worries you about the patient, about the team that's going to look after the patient, or for the overall organization. So shortly after he's admitted, he's being sent to a theater, and he comes out of theater, and the surgeon says, look, on the whole, everything, well, it was a bit harder than we thought it would do, and it took very significantly longer, 2.5 hours longer than was expected. So let me know if that's something that should worry us at this point in time. I'm going to continue to go through the story, and we're going to repeat this question a couple more times. So over the Friday, Lewis is in quite a bit of pain from the wound. He gets some non-steroidal analgesia. There's some notes in the nursing notes to say that he's not passing a lot of urine, and he's on the whole, he looks quite pale. And over the day, he starts to develop some abdominal pain. Um, and he's reviewed, and the team thinks that maybe this is some constipation and after surgery, and that the bowel hasn't worked, so he should get up and walk a bit about and see whether he can loosen his bowels. So on the Sunday morning, he is still no better. He's actually in a lot of pain now. He's really quite pale. His mum notices that he's sweaty. He's got a very low temperature. He's got a low temperature, and mum asked to speak to a doctor, and she asked several times to speak to a doctor, and eventually the resident is coming, so the intern, so a first-year doctor is coming to see. Is that something that should worry us at this point in time? So we've got a sweaty patient who's got a low temperature, and we've got a fairly junior member of the team who's assessing him, who's wondering whether this is still the same problem as the previous day, who's prescribing some more painkillers, and then proceeds. Now, overnight, Louis starts to become tachycardic. His heart rate is initially 80, then 126, and then 140. Mum is really concerned now. She's trying to get the doctor several more times, and it's a rather a difficult night. In the morning at 8 o'clock, the nurses try to get the blood pressure, but they can't get the blood pressure. They attribute this to a problem with the blood pressure machine. They get another blood pressure machine. They still can't get the blood pressure. The heart rate is 146. Louis is very drowsy. And overall, they try to get 12 times the blood pressure, and they use 7 different machines. How concerned are you now? So everybody's now concerned about the patient, about how the team is coping with this, whether we got the right people at the bedside, and how the organization has put systems into place that don't allow this to be escalated in a timely manner. At lunchtime, Louis gets more painkillers and then suffers a cardiac arrest and dies. Now, Helen has become a very vocal advocate for patient rights. And we've worked together with her to develop guidelines for rapid response systems in 2018, when I had the honor to chair the International Consensus Conference from this, and I'm going to talk a bit about this in a few minutes. But it seems to be that when things go wrong, it is often several things that are colluding, and it's often systems that are set up in a way that is likely to fail. And this literature is not new. In fact, it goes back to the 1980s. Since then, we've known that most cardiac arrest time patients who are known to be unstable, often with changes in mental function or respiratory function, and that those abnormalities are often over prolonged periods of time, in fact, in 2/3 for 6 hours or more. Similar facts have been found if we're looking at unscheduled intensive care admissions. I was one of the data collectors on this 2005 report from the National Confidential Inquiry for Patient Outcomes and Deaths, and we found defined physiological abnormalities for up to 72 hours before patients were admitted to intensive care. All this is of grave concern, and is of grave concern because it's been present for a fair amount of time and hasn't changed that much. In this article in 2018, Jeffrey Braithwaite outlined that only 50 to 60% of the things that we think are evidence-based have actually got a robust evidence. 30% have got no use whatsoever, and 10% of the things that we do in healthcare are outright dangerous and harmful. And the fact that that hasn't changed that much is of concern, and he reviewed the methods that are probably successful if we want to change things. And 2 of the drivers that he highlights are if there's new technology, something that's a real breakthrough, a game changer, or new models of care. So you can't do the old behavior in a different system. And those, I think, are important learnings when we think about how do we create systems that are safe. Most of you are probably familiar with the definitions of safety 1 and safety 2, with safety 1 being focused on the analysis of accidents and disasters, where safety 2 is trying to learn from the way that we get around risks in everyday clinical practice and put those into more robust systems. So this is the background of why people have started to develop rapid response systems in the 80s and then 90s. The developments were pretty much in parallel, and we've undertaken in the last few years 2 international studies with colleagues from Australia, the USA, and Europe. And we looked at hospitals, and they submitted data on small groups of patients. And it was striking how similar these group of patients were, despite the dramatic differences in healthcare systems. The severity of illness in this left graph measured with the early warning score. So we adjusted vital sign sets that we were given to this, are the same wherever you go. And increasingly, we are seeing patients who are not young and have an unexpected illness. We're seeing patients who have got significant comorbidities and who are frail. And frailties is an important predictor of outcomes. And we were able to show that in the group of patients who are significantly frail, more than 60% have adverse outcomes. That means that they either die as a consequence of a deteriorating event or are still in hospital or in an institution after 30 days. And again, this was very similar globally. So the crises are similar and the patients that we're seeing are similar. What are the systems that we're putting into place? And this is a graph from the first International Consensus Conference chaired by Michael De Vita. And in essence, they set out that there should be 4 parts in a successful rapid response system. There should be an afferent limb with usually physiological detection of deterioration, an afferent limb with healthcare practitioners who are either coming from intensive care or from a dedicated team to respond to this, and then an administrative and audit arm to monitor data. And we're going to talk a bit about the different parameters that you can use for the afferent limb in the next part of this presentation. There's very little known about what represents a good afferent limb. And in fact, I'm proud to be part of the supporting team for a randomized control trial that's at the moment starting in Denmark, where they're going to try different forms of response and see how that changes clinical outcomes, which means that we're actually left with very little. And so this is the consensus conference that we held in 2018 with faculty from 5 continents, quite literally, where we looked at what makes a successful rapid response systems and how do we measure that. And if you're asking for the elements of a successful team, then a timely response to abnormality is important. And we would obviously like to say what that means, but it's quite difficult because everybody's using different call-out criteria. So for the purposes of measuring, as we said, you should have a policy, you should write it down. But most systems would say you got significant abnormalities and these should be attended to within 15 to 60 minutes. For timely admission to intensive care unit of patients who are deteriorating, we've been significantly more specific. We thought that we had enough data to say, if there is a patient who requires intensive care, they should be in intensive care for the latest within 6 hours after they first get flagged up. And there's data from a number of studies to say this is probably something that you can specify and measure, and that will help to improve outcomes. And you should measure what cardiac arrests occur, and particularly whether they occur after physiological abnormalities have been triggered on your local trigger system. We came up with a suite of other metrics that are beyond the scope of this talk, but safety culture is something that can be measured in questionnaires, and that's probably as important as all the other things that we'll talk about today. Now, there's different track and trigger systems, triggers to call out this crucial response of a team who knows how to deal with critical illness, who can assess the sick patients, order the right tests, and instigate the right treatment. And we started looking into this in 2000. In February 2000, in fact, we started the first study on this, which led to the first publication on early warning scores. And we collected data on just under 700 patients and followed them and their vital signs for 5 days, and then looked at clinical outcomes after 60 days. And we were able to show, unsurprisingly, that the more abnormal vital signs you've got, the worse is the outcome in terms of mortality, the chance to get admitted to intensive care, or in fact to have cardiac arrests. Now, I would be curious to see what type of systems you are using in your hospital, and if you still got your mobile phone up with menti.com, and you can give me the code to type in the code 236701 and let me know whether you're not using any system in your local hospital, whether you use a single parameter triggers, so where you define below a certain respiratory rate and above a certain respiratory rate, below a certain heart rate and above a certain heart rate, your local team should be alerted. Whether you're using a scoring system such as Muse, whether you're using a system that's at the moment spreading rapidly around the globe, which is the National Early Warning Score, and I'm going to talk a bit more about this in a moment, or maybe you're not sure which system is locally in use, and that's also okay. So there's quite a few people who are using single parameter systems, and there's a couple of people who have submitted that they're using an early warning score. Now, there is increasing amount of research that has compared those scoring systems. Now, I have to put a note of caveat in when we're talking about this research, because it is usually done on data sets. So we're taking a data set of vital signs. We know what happened to those patients, whether they died, whether they reached intensive care, and we then do sensitivity and specificity analysis on this data set and draw conclusions how those systems might behave. That is quite different from implementing those systems in clinical practice and seeing whether people actually understand them, like them, and use them. So whenever we say this system is really good for a physiological trigger system, I would urge you to have some caution what that actually means and whether there's data to say this is actually a system that helps to save lives or detect patients earlier in clinical studies. Now, Gary Smith is probably the person who's done most work on this, and this is a study where he compared no less than 33 early warning scores. I think our Muse is this one here. On the right is the National Early Warning Score. At that time, it was called the VitalPAC Early Warning Score, and all the other ones are pretty much of a muchness. So there's one score that sticks a bit out, that's got better sensitivity and better specificity. Now, he's done the same study with single parameter early warning scores. And I don't want to disappoint those of you who are using those. If you're looking at sensitivity and specificity to predict adverse events, they're all significantly worse than any of the scoring systems that are in this slide. So this is the National Early Warning Score. This is what's being prescribed in the United Kingdom and has been used in a number of other settings, and has been validated now in a large number of different patient groups and healthcare systems. And we think that it's a reasonable system because of its behavior when we're looking at work efficiency. So I hope that you can see my little mouse here at the bottom. So if, for example, if you want to pick out 80% of patients who will die within 24 hours of an abnormal score, and you do this with the National Early Warning Score, then you would need to see up to 20% of all patients. Now, if you're using a score that's worse than that, that has not got the same sensitivity and specificity, then you might have to see 30% of patients to reach the same amount of patients who are likely to face deterioration. So having a system that's got worse sensitivity and specificity has got some very practical implications for workload. And then there's obviously the really sophisticated, funky AI type of machine learning involving scores. And Dana Edelson's ECART is probably the most prominent and best researched of those. Dana works in Chicago. This is a study that they did with an Australian group where they looked at data for cardiac arrests And you can see the between the flags is a single parameter trigger from Australia versus Muse, versus News, versus ECART. ECART is better. Now, the problem with ECART is that so far, we don't know whether it actually changes clinical results. And that probably matters. I'm going to slip over those two. So we now got the single sign triggers. We developed some scores that can be used for single diseases. So the one that I flipped over is a score that's for patients with chronic obstructive pulmonary disease that adjusted to the normal physiology for this patient group. So scores saturations in a different way. And technically, you can actually personalize your triggers. So you can say, I normally have got a slightly higher heart rate and a lower blood pressure, so this is normal for me. And locally, we're certainly using this in the community for patients with chronic illnesses to know their own news. And you can use artificial intelligence. Does any of this stuff work? Does it actually make a difference? Let's have a look at a bit of data. So when we introduced the National Early Warning Score in 2012-13, with this protocol, so we defined in a group of 16 hospitals that looks after a population of 3.5 million patients, triggers at levels of 3, 6, and 9, with 6 being the trigger for a call out of a doctor and 9 a call out of intensive care. We could show that our mortality from sepsis within 12 months dropped by 20%. Now, this was not data that we decided to collect. This was data that was already being collected, which made it very beautiful to use because it's not our bias. It is objective data. And my good friend Helen Hogan has done another study to see what happened when hospitals changed their systems. And she looked at the National Cardiac Arrest Audit data set, which includes 106 hospitals, and looked at data from 6 years. And she was able to show that if you got a non-news score type of system and you switch to news, that the mortality, so the cardiac arrest rate dropped by 9%. And the same type of response happened if you switched from a paper to an electronic track and trigger system. Now, a note of context here. So most UK hospitals haven't got full electronic health records. Many hospitals have only got electronic temperature pressure charts. So the vital signs are being entered into a tablet type of computer. And so that had a significant measurable impact on cardiac arrest rates. So there's some evidence that if you introduce something like this, that you can use as common language across a broad range of healthcare professionals, that you can have a measurable impact on clinical outcomes. We built on this for our Vital 2 study that was published in 2017, where we did a before and after study with the control group of over 2,000 patients in 2 wards, collected over 12 months period using standard care, and then an intervention period where we used an electronic system, again, following patients for a year. The model that underlies our philosophy of care is this. We think that you need to record safety critical data. Somebody needs to recognize that it's abnormal. It needs to be reported to a responder. That responder needs to do the right thing. And often the response to deterioration is not complete, and therefore the whole cycle needs to be repeated. We know that if systems fail, it is often that vital signs are not properly recorded, especially respiratory rate is often imprecisely recorded or guessed. Measurements are often delayed. The recognition that they're abnormal depends to a degree on the mindset of the person who is doing it. Have they got the capacity to realize that there's something abnormal? Have they got too much cognitive load so that they overlook this? And then we know that escalation is also regulated strongly by social norms, so often things don't go as they were planned. So for this study, we used a spot check monitor from Philips called MP5 that can calculate early warning scores and transmit them wirelessly to responders. So we paired that up with some wireless sensors that measured respiratory rate and heart rate on the patient, And now we got a system where we can be sure that in those where it matters, we get reliable vital sign recordings, and we can escalate them without being dependent on a human intermediary. So this is the rest of the kit. So on the right, you got the respiratory sensor, and here it's on the patient. This is the spot check monitor. And then in the middle of the wards, we had these big whiteboards that showed all the vital signs. And even if you're not familiar with this, you can see there's lots and lots and lots of different data, and it's very difficult to see what's happening. But actually, the only column that matters is here, because that's where the national early warning score sits. And you can see they're color coded, so I can see very quickly what's happening here. And I'm just going to blow this up a bit. So this is an enlarged way, and so you got a little trend here. So I can see, okay, this is somebody who's really sick, but they've been sick for a wee while. This is somebody who's is getting better. He's had a couple of blips. This is somebody with chronic respiratory condition. And this is somebody who's just starting to get bad. He's just been admitted. So this is somebody unstable. So if I come to the ward and I've only got 20 minutes, I'm going to ask about this patient and I'm going to see this patient. So it means from the hundreds of vital signs that we're collecting each day, I only need 2 numbers, which makes it much, much easier for me to respond. And then I got the whole thing on a mobile phone that I can carry around with me. So this is how we affected the system in this trial. So rather than having vital signs reported by somebody junior, then reported to a senior nurse and then escalated to somebody from intensive care, with all the problems of this data transfer that comes with this, we can just report that data straight away to the responder. So here's the data. Over 2,000 patients in control and intervention group. The groups were reasonably well matched in age, gender, length of stay, severity of illness on admission, case mix, amount of patients with respiratory conditions, and so on and so forth. And when we looked at how many callouts we had with the automated system, we had about 15% more callouts. And as a result, patients who were sick had more fluid boluses, more antibiotics, more bronchodilators, but less hours of ventilation in intensive care. And in terms of clinical outcomes, adjusted for severity of illness and case mix, we reduced mortality by 20%, reduced severe adverse events that were predefined by a third, and we reduced cardiac arrest from already a low rate by a further 86%. As far as intensive care admissions went, there was a real worry that everybody would get referred to intensive care with this automated system. That was not the case. We reduced intensive care admissions. That's not significant. But we reduced severity of illness, and that was significant and translated in better mortality with a drop by 66%. So we've obviously had some thoughts on why these things happened in the way that we saw them. And one of the models that we've used to explain them is something that's called modular redundancy. And it was made popular by the Apollo mission, which on its lander module had 2 computers that were able to do exactly the same functions independently. So if one of them went down, there was a second one that could take over seamlessly. Modern planes have got all safety critical hydraulics and electronics in triplicate. And the latest generation Airbuses has got all safety critical technology in quadruplicate. So quadruple modular redundancy. This is something that we don't do in healthcare. I showed you the little chain earlier where one nurse hands over to another nurse, hands over to another doctor. That's a very, very fragile system. So by having an architecture where the data is with several responders at the same time, we can significantly improve reliability of the system. So the bedside nurse knows what the vital signs are. The shift lead in the nursing station knows what's on the display. And for the study, we had some simple pages that paged out to the rapid response team and the resident, the senior resident, abnormal vital signs, the bed, and the telephone number to call. So by that, we distribute safety critical information, and we've got a much more robust and reliable system. And this is where I'm going to come to social networks. So we know from social networks that human beings like watching what other human beings do. They follow them. They like to be liked by other human beings. They look what their peers are doing. So by connecting people and showing them the similar data, they start to behave in slightly different ways. Now, sharing this data is really important. And this is not a normal Facebook page. This is actually a Facebook page to detect catastrophes and link people who are in the same region to these catastrophes to detect them early. So this is another application of networks. We used the same mechanisms to get our patients involved in observing their own vital signs. So this is a project where we asked patients at risk of acute kidney injury to monitor their urine output. They got a little bracelet and they were telling nurses about the color of the urine. And by the pure fact that they did this, the amount of urine that was charted increased by a factor of 3, just by social networks. And we just published a report where we asked patients, their families, and healthcare professionals to use checklists that were linked for side effects of cancer treatments. And in an ongoing study, we're testing whether patients can actually make sense of their own vital signs that comes directly of the Philips Guardian solution that we used for the Vital 2 study. I'm going to finish with a couple of thoughts on the challenges of transitioning from a paper to an electronic system, and some thoughts on electronic healthcare records. For the Vital 2 study, we modeled very closely our existing workflow. And I think that was one of the reasons why the study was easy to do and a success. So the nurses did not feel it was something that they had to do differently. They took the same vital signs. It just happened that they were already then in a device that knew what to do with them and could calculate them. They perceived the calculation of the score as a real help, and subjectively their workload went down, though I'm fairly sure that objectively that was not the case. With the big screens and the very graphic display and the colors, we can reduce cognitive load of having lots of patients that we need to look at the same time by being able to pick out very quickly what the data points are that matter. And we've done a bit of modeling around this, so clinical teams on a normal working day see more than 3,000 pieces of potentially safety critical information. So to have a system that structures this data is absolutely crucial, and that understands the interdependency between those parameters. Now, most electronic health records don't do any of this. Most of the screens are very simple, very basic, and as in paper records, a lot of safety critical data is hidden within the small print of the system. The systems often take longer to enter data, and the records are as segmented as paper records in many ways. And we just finished a scoping review on safety impact of electronic health record, and there's extremely little evidence for this outside of medication safety. And while this is an advertising point for electronic health record that they make care safer, there's very little to suggest that is the case in the literature that used interventional studies or validated control groups. Going back to Helen, Helen is a campaigner for safety who sits on the board of the Institute for Healthcare Improvement and is very involved with the WHO. We worked with her to develop metrics for rapid response systems to look at the system impact on how we can help deteriorating patients. And we think that patients have got a very important role in flagging up when and sit as one of the partners in the systems of modular redundancy, and therefore are allowed us to do things better and safer, a new era of safety, if you wish. So in summary, failure to rescue is predictable, often preventable. Successful rapid response systems are this. They are systems, they have to work at every level. If you're looking for the right trigger for rapid response systems, think about what is the common language that you can get your teams to speak, and weigh that against personalized scores or scores that have got a lot of different numbers and high cognitive load. In the Vital 2 study, we were able to show as that modular redundant systems are probably more reliable than systems that don't have those type of features. And as I said, there's limited evidence for that this type of functionality is replicated in electronic health records. I'm just going to have one little plug. Tomorrow we were meant to have a webinar as part of the Critical Care Congress. So we were meant to be in Canada, actually. And so we've got a webinar where we're going to talk more about rapid response systems on the 12th of December. It'd be great if some of you would be part of that. And I hand over to Randy.
That's great. Thanks, Chris. Fantastic talk. We are just waiting for the audience to start submitting questions. If you don't mind, and actually for the folks organizing, maybe you can get both Dr. Subi and I, but perfect, that's great. That's where we can interact together. So a couple of comments I'd like to make before we look at some questions from the audience. The first is the importance of the timeliness of getting the patient data and having somebody interpret it in some way, ideally in some kind of scoring system to indicate, is this patient sick or not, and do we need to do something or not? I think it's incredibly important. And I think the paper towel or the scrub suit documentation of vital signs that get translated, later, even if you have an electronic medical record. So, you finally enter the numbers on the computer, and then 8 hours later, when they finally enter it, you get an alert saying that patient was sick 8 hours ago.
Yeah.
That's a real concern. And I just wondered if you wanted to comment or emphasize that timeliness of integrating the data.
No, I think that's a really good point. And so the system that we used is one of the few that actually is able to do all of this in real time. So the moment the vital signs are taken, they are live and they go to the responders. That might be scary because the nurse that takes the vital signs knows that somebody else knows. And we all know if somebody looks over our shoulder, we behave differently than if nobody looks over our shoulder. So there's none of this writing on paper towels or on the scrubs, which a lot of other systems are still using. I think there's a couple more systems. I obviously work with Philips, so that's my bias, but there's other systems that have attempted similar things. But I think that's a really important part of the process. Now, an interesting question would be, how fast should you be with somebody who's got, let's say, a blood pressure of 80 and a heart rate of 120? And we don't know. Because obviously you take the blood pressure at that point in time, but we've got no idea for how long the blood pressure has been at that level. And there's a chance that it could have been at that level for 4 hours. So if I say you should be there in 15 minutes, but the blood pressure's been already in like this in 4 hours, then maybe the impact of those 15 minutes are actually not as big. And so what is probably more important is to determine how often you should do the vital signs so that you determine how big are the gaps between your measurements. I'm involved in some work from a group in Portsmouth and Oxford who are doing a very interesting study on this at the moment. So we're able, hopefully, by the end of next year to answer this with some authority. In the study, we worked a bit with wireless sensors. So we gave teams the opportunity to have those patches for respiratory rate and heart rate. And for patients who are very unwell and unstable, I think they're a real addition. For patients that are mobile and walking around, they're a real challenge. Because these machines give you lots of data and they add to your cognitive load. So I think they're probably good for targeted interventions. And they get around this problem that you don't know whether the vital signs that you got has been abnormal for 4 hours or whether it's abnormal just now.
And it's great that you mentioned the issue about the respiratory rate. I think anybody who's passionate about rapid response systems and early warning from early days, looking at what are factors that are sort of best predictors for patient deterioration, the measurement and documentation of respiratory rate is something that's been a challenge. It seems that everybody has a respiratory rate of 16 or 18, whether they do or not. Just wondered if you wanted to comment on the ability to directly measure that and have that interface with your system so that you can
Yeah.
properly not only
No, no,
document but also
absolutely.
measure.
Mm. Yeah, no, absolutely. So I've had a couple of slides in the slide deck that I took out in the interest of time, but I can assure you that our nurses are significantly better than doing just 20s or 16s or 18s. So we've got live data of hand-counted respiratory rates, but it's all even numbers. I think that's still true. And Dana Edelson from Chicago has got this very interesting theory that people only start to count the respiratory rate if they think a patient is sick. So if they see that the breathing is labored or other vital signs are abnormal, that's when they actually count the respiratory rate. And before that, they more or less guesstimate. But we were able to show in one of our studies that once you measure electronically, you get a very neat normal distribution as you would expect from your physiology, and that distribution looks quite different from what is manually collected. Now, what's interesting is that patients in hospital, on the whole, breathe faster than patients in outpatient clinics. So when we look at what's normal from our physiology book, we might say a respiratory rate of 12 is normal, or 14 maybe, or even 10. But most patients who are unwell have got higher respiratory rates. So the average admission respiratory rate is 22 in a medical cohort, obviously not in an elective surgical cohort. And that's because respiratory rate is so important for metabolic parameters, for respiratory parameters, for anxiety. It all comes out. And so hence we've been working very hard with Philips to refine those sensors that measure respiratory rate automatically. And we think that they add an element, again, of reliability in the patients where you really need it.
Well, that's great comments, Chris. Another question that comes up relates to the difference between point measurement of the patient or assessment of the patient and trends over time. And certainly, if you've got a piece of paper in front of you, even if you're writing the numbers, being able to see the trends sometimes is challenging. And then when you're trying to integrate, say, different vital signs or other things that you're monitoring to tell whether or not the patient's sick or not, sometimes it becomes difficult being able to tell the difference. I mean, most people, if they go into a room, they see the patient's breathing 40 a minute and has a blood pressure of 60 systolic and a heart rate of 40, will recognize that the patient's sick. But it's those more subtle signals about change in the patient's condition from their usual baseline that often are the earliest signs that something's wrong. I just wondered if you'd like to comment a little bit on how or what you've learned from your work about the importance of that trend and issues or barriers that people have in noticing the change in the condition of the patient, as opposed to just focusing on the point assessment that they're doing one point in time.
Yeah, no, absolutely, and that's a really important point, and I think we're only at the beginning of learning about trends where we are at the moment. I showed you the slide where there's these little trends that tell us where the National Early Warning Score came to where it is now, and to have somebody who's chronically ill and maybe somebody who's dying, who will have abnormal vital signs for 1 or 2 days, or somebody who's had normal vital signs and then suddenly they rise and rise and rise. Those are two very different patients, albeit that they might at the given point in time have exactly the same early warning score. And we have started to work with machine learning. We've just published our first paper to look at stability of patients as a trend derived from trends in vital signs. So using mathematical algorithms to say whether somebody is likely to have trends that are continuing to improve or adverse events. And this is something that can be used as an adjunct to measurement of patient flow in hospitals. So we're just, I think, at the beginning of that part of the journey. But I thought that the little graphs for me have been one of the real beautiful additions to the Guardian main screen, and that you can see very quickly which way are things going, and that often tells you more than the absolute number. Is that what would you do in your practice, Randy? What
In
systems
terms
are
of
you
looking
using,
for trends?
and how do you get your
Sure.
trends? Mm,
Yeah, it's an interesting question. So we actually use a bit of a hybrid right now. So we have an electronic medical record in some of our sites in my hospital. We're a multi-site sort of hospital corporation, and we've had one site that's sort of joined us recently. So there's a little bit of incompatibility, and we're trying to work our way through that. And we've
mm,
actually were using Muse before.
mm,
And we
mm,
actually would have that integrated in our electronic health record. And so it would generate a
mm,
score, and then we did have thresholds for generating color
mm.
alerts for patients. And so
Yeah.
there's supposed to be a an action taken based on the Muse
Mm,
score. So we've done a couple of
mm,
interesting issues. The first would be we were definitely seeing a problem with the paper towel documentation and the later entry. And
mm,
so we, the majority of our rapid response team activations were really coming from single parameters, which I
mm,
agree with you. I mean, the
mm,
sensitivity, specificity of single parameter monitoring, it will catch something bad, very bad, but you're not
mm.
going to catch it
Yeah.
potentially as early. And so
Mm,
by the time somebody had actually entered the vital signs in the electronic health record, most of the time something had already happened to the patient, or nothing
mm.
happened to the patient, and the story's
And they
already
got better.
mostly done. Yeah, by that time.
Mm,
And so,
mm,
that was certainly a concern, and we were trying to figure out how to get around that. We're
mm,
actually some of the comments you made about the shift from paper-based to electronic, very timely for me, and I really appreciate it. We're working with a multi hospital system in our region, and all converting over to a new clinical information system at the same time. And so,
mm,
our one of our challenges has been really how do we take hospitals with different resources, different vital signs monitoring equipment. How do we take all these people who've been doing things in a different way, and how can we try to standardize that
mm,
so that we can all approach the detection of the deteriorating patient in a uniform way?
mm,
And I think the
mm,
beauty of having a common system, and to be honest, I've been a bit jealous about this with news in the UK and the deployment with the NHS is that for better or for worse, you're probably better off with everybody doing the same thing so that you can at least
mm.
share education, do things the same way, measure it. It doesn't mean you can't improve,
Yeah.
but at least you
Mm,
know what you're dealing with. And I think chaos has actually been a real challenge in trying to understand what to
mm,
do. So
mm,
I'm looking forward to our transition to a full electronic clinical information system and seeing how this works. But along with that, you have the challenges of calibration and trying to understand what's your
mm,
thresholds for triggering certain actions. And so it's to some extent we have to start from scratch to understand how to make the system work to our benefit and get that sensitivity and specificity calibrated. But I do think what you've talked about today, the importance of being able to eliminate some of those barriers and delays in getting the patient assessment translated into an assessment of risk and a prediction of deterioration has been very helpful and certainly very
mm,
encouraging, because I've experienced that's one of the biggest
mm,
challenges. And with many of the older studies, the it was a little bit like watching a horror movie, where people would drive up to a house that was all dark with lightning, and the door was creaky as they would walk in, and you'd be watching the movie and you'd be screaming at the people walking in saying, do you really want to do that? You know what's going to happen to you, something really bad. And it always felt when you were doing these post reviews and you'd be
mm,
looking at the story, you'd be looking at the vital signs, and where this is going, right? And of course, you have the benefit of doing
mm,
it
mm,
retrospectively, but it'd be nice to be able
mm,
to recognize this
mm,
in time to actually help the patient, as opposed to retrospective reviews. And so I
mm,
think for many places that have some work to do, I think to be able to do a better
mm,
job of predicting and detecting these patients, I think some of the lessons you've mentioned today, I think are very, very important. There's one more question, if you don't mind. Maybe we'll just
mm,
throw it. So it says,
mm. Yeah.
how do you set triggers that are sensitive enough to detect patient change, but not so sensitive that the Met's inappropriately called, and that calibration? So I don't know if you want to add
Mm.
some comments to that.
Yeah.
Yeah.
Um, Now, this is actually slightly embarrassing. So there is a national protocol set by the Royal College of Physicians, and I sat on the working party that issued it. But we're using a slight deviation from it. So our trigger for a call out of a MET is a national early warning score of 6. And the way we derived this, so we were coming together with 16 hospitals, all having their own scoring system, their own protocol, their own way to respond. And basically we went, so this is a very rural area, not quite as rural as some parts of Canada, but we would drive once a month to this place in the middle of nowhere, and we'd sit together and we said, everybody brings 5 patient charts with them, just the vital signs. And we put them, we chart them, and we looked with our existing systems, they would trigger, and then we would look, how they would trigger with news. And we reached a consensus that from the workload that we could handle with the teams that were responding, that 6 was the right trigger. Now, the national protocol is actually 5 for the UK, but especially in some of the very small and the very large hospitals, there was a feeling that they didn't have the team that could handle, 5. A score of 5 is many more than a score of 6, because this pyramid is a bit like this. You got tons and tons of scores that are 0, and then you've got quite a few that are 1, and so on. And it's more and more narrow towards the top. So we could say we can handle that many calls a day safely, reliably, every time, regardless what happens. And that's what we went for. So that's how we achieved this. And now we had a bit of data. So Gary Smith was kind enough to give us some simulation from his data set, and they had an electronic system that collected tons and tons of data. So we were able to see, whether what we thought was right was right. And so that's how we picked that. So 3 is escalation to senior nurse on the ward to see whether patients need more frequent vital signs, whether they need a urine output chart, and other blood cultures, sepsis bundle, this type of stuff. Then 6 is escalation to the MET doctor, and 9 is intensive care.
Oh, that's great. I think, Chris, it really emphasized an important point, because one part is the monitoring, the detection, and then really trying to understand how we respond really does have to depend on what resources you have available and where you are. And for example, in hospitals that don't have intensive care support, and they have to reach out to somebody else, they may have to handle things in a different way. But the system can still work. So that's great.
And I mean, so there's been questions, whether you should adapt parameters, or whether, as you say, you just adapt the threshold. So it's still the same score. We can train everybody in the same way. You go to another hospital, it's exactly the same score. The nurses use the score, the doctors use the score, the physios use the score, the paramedics use the score. The paramedics come in with the score. So everybody speaks the language.
That's fantastic. We have another question. From an artificial intelligence perspective, how do we teach it to learn which patients are considered palliative care versus those that may require ICU?
Brilliant question. Absolutely amazing question. And I think at this moment in time, we haven't got a good answer to this. And that's been one of the real challenges. So again, I'm involved with a study in Oxford who's trying to resolve this type of issue, looking purely for patients who might require escalation. But I think that's really, at the moment, our gift as clinicians to discuss with patients and the clinical team what is an appropriate escalation plan for a patient. I didn't point it out, but in our Guardians system, we got 3 protocols. We got the normal protocol, then we got the respiratory protocol on the respiratory unit that can only be activated by a very senior member of staff, and then we got a palliative protocol where we are measuring vital signs, but we're alerting a MET. Can program this into the system, and that's not AI, but that's, I think, clinical judgment. And I think the important part is that this is really a decision that has to be done with the patient, and AI can't take place. So we need to discuss with the patient whether they are palliative, or whether there is a set of circumstances where we would recommend a short stay in critical care for a specific intervention. And so in that sense, I think that's probably at the moment one of the limits.
And I'd support what you said, the importance of actually detecting these patients who do need that end of life or palliative discussion. And it's interesting because when you speak to some people who maybe don't spend as much time thinking about patient deterioration or involved in rapid response, they ask, oh, aren't you frustrated when your warning systems are triggering all these calls for all these patients that probably should never go to the intensive care unit and should be palliative? Aren't you frustrated? And what I always say is absolutely not. Like if there's been an opportunity or missed opportunity to have those conversations, and if the early warning system triggered a response to get some people to the bedside who can recognize that there's a mismatch between the end of life plan and the situation for the patient, that's a
Can I ask,
blessing. It's an
changed
opportunity.
during COVID, Randy? Has that changed during COVID?
Interesting. In terms of how we're responding with our early warning.
Yeah. So are those discussions earlier than they were before, you think, or?
I do think so. I think it depends on leadership in various regions. I would say, where I work, there were a lot of upfront conversations even before the patients came into the hospital. I think particularly in long-term care facilities, nursing homes, where I think in a lot of places the physicians had some, I think, important and frank conversations with patients and families about, what the likelihood would be of doing well with if you got sick enough to end up in intensive care, and for people who had a lot of comorbidities and just likely would not have a good clinical course. And so I think that actually was very important. And in some ways, just like I think COVID has changed so many things about life and moving forward, about what's it like to go to a restaurant or to go work out in a club, and when you're feeling sick, do you go to work or do you stay home? So many things have changed, and I think it's going to be very interesting to see from an end of life perspective how people reflect on what's happened. Certainly some places of the world have experienced even more tragic circumstances with COVID than others. But I think in general, I think it's made us all think a little bit more about, what do we really want for our health, and what do we want for our lives. And what I would say is, other than some tweaking about things like the ROX index, for example, looking at high frequency nasal cannula and prediction of need for intubation in COVID patients, which is very specific and may or may not necessarily pick up the same patients. It might similar to what you were talking about with single or diseases or specific diseases, where if you design some kind of scoring system for a particular disease, it may be slightly better in sensitivity and specificity than taking a generalized early warning system. But at the same time, there are so many different diseases, and how many scoring systems can you have? And so I think at the end of the day, being able to have a well-functioning system for detection and a well-functioning system for response, and something that you can calibrate and monitor, and all the various arms of the rapid response system, the holistic approach, I think is extremely important. And so even with things like COVID that's a specific condition, I think it's much more important to have a generalized approach, and then we can tweak it and add on as needed. But I think if you work in a place where you don't have a good early warning system in place, and you don't have timely ability to predict these deteriorating patients and intervene, the likelihood that some specific intervention for a specific condition is going to help you, I think, is very low, because the basic infrastructure for supporting rapid response isn't there. So that's my experience. I don't know if you've seen anything different where you are.
Yeah. No, I agree with that. I think that's a good summary.
Great. Well, I believe we are actually a few minutes over time. We are very grateful for the participants for joining us, and the questions that they put forward. Grateful, Chris, for your participation and getting an international perspective. The Critical Care Canada Forum is usually international. We have some great speakers, and obviously we've had to shift to a virtual format this year, but we're really glad that you were able to join us. And specifically thanks to Philips as well for helping to sponsor this event. I think all of us who are responsible for the healthcare system are always concerned about trying to do the right thing, and so I'm glad that they were able to help us have this opportunity to hear from your experience, and I think get some very good advice for many of us moving forward. So thank you very much for joining us, Chris.
Yeah, thanks for me as well, to you for chairing it and hosting it, and to Philips for sponsoring it, and for Critical Care Canada to continuing to enable education, because there was a real worry in the earlier phases of the pandemic that education would be one of the victims. And I think it's great to have these new platforms where we can still learn together, and long may it last.
Well, I enjoyed working with you virtually on this, but hope that we can come to a day where we can sit down and in a nice pub somewhere and enjoy being there in person as well, hopefully when the pandemic's over, sooner rather than later. Thanks a lot, Chris. Thanks a lot, everybody, for joining, and wish everybody a good evening or afternoon. Take care.
Take care. Bye-bye.